Good morning or good afternoon. My name is Tracy Cooks, and I am with Saks Healthcare Communications. Before I introduce our moderator and speaker, on behalf of Medtronic and Saks Communications, we would like to thank all our frontline workers in our audience for your commitment and passion in helping us all through this very difficult time. We are truly indebted to all of you. For today's session, you have the opportunity to hear translation in Spanish or Portuguese. Step 1, please open a Chrome browser and go to the link that is listed. I've also pushed it out through the questions box. Please type in the password hashtag webinar2. And then step 2, you need to go to and mute yourself on the GoToWebinar control panel. Click on the GoToWebinar tab at the top of your browser and right-click on the GoToWebinar tab and choose Mute Site. You should now only hear the translated version. You have the opportunity to submit text questions to today's presenters by typing your questions into the questions box. You can also download a copy of today's presentation in the handout section of the control panel as well. Our moderator for today is Fernando Yusti. Fernando is a Senior Global Principal Training and Education Specialist at Medtronic. He has over 20 years of experience in the medical device industry with positions ranging from management, sales and marketing, product development, clinical affairs, and business development. Dr. Yusti holds a PhD degree in physics from the University of Madrid and an MBA marketing specialty from ESAD Business School. Fernando, welcome.
Thank you, Tracy, for a very kind introduction. Before we start today, because this is a special week, I want to say thank you to everybody on this Thanksgiving week. I want to wish you a great Thanksgiving, but most of all, I want to thank you for what you do in these very difficult times. You guys are in the front of this pandemic, and you're holding us there. And so again, thank you very much. With that, I'm going to introduce our first speaker today, Ashish Khanna. Dr. Khanna is an anesthesiologist and intensivist at the Wake Forest Baptist Medical Center in Winston-Salem, and he also works at the University Wake Forest School of Medicine. Dr. Khanna serves on several editorial boards, including the Journal of Critical Care and the Annals of Intensive Care, and he has published extensively in peer-reviewed journals on several perioperative topics, including opioid-related respiratory complications and the prediction of and monitoring for cardiorespiratory complications within and outside the ICU. He is actually part of the study called Prodigy that was recently published this year, and he has presented extensively on that as well for us. Our second speaker is Katie Bull. Dr. Bull has been a nurse for over 16 years and recently completed her doctorate in education. Her clinical areas of expertise include pediatric and post-surgical nursing with a research focus on adherence to evidence-based practice and airway management. Katie spent many years teaching in undergraduate and graduate nursing programs before we luckily got her here to work with us in Medtronic in 2017. I am very thankful to be able to work with both Ashish and Katie on this endeavor. The faculty disclosures is that Ashish Khanna, Dr. Khanna is a consultant for Medtronic, and he also, as I said before, belongs to the steering committee of the Prodigy clinical trial. Katie Bull is an employee of the medical affairs department at Medtronic. Today's presentation is going to be accredited for CEUs for nurses, EMS professionals, and respiratory therapists. At the end of this event, we will give you a link to tell you how to obtain this certificate. With that, I want you to join me. Welcome, Dr. Ashish Khanna.
Thank you, Fernando, and hello everyone again. We are going to present to you today a review of tracheostomy tube choices, tracheostomy tube technology, talk about some adverse events, and talk about um, a little peek into the future with some latest and greatest, and then give you some best practices on how to manage a variety of tracheostomy tubes and assure that your patient has a safe recovery while the patient's with you in the inpatient hospital setting. So, sorry about that. I already talked about learning objectives, but just to summarize again, we'll start with a discussion of tracheostomy tube types. We'll understand why we choose a particular tracheostomy tube. We'll focus on some adverse events, and I'll talk more about ventilator-associated pneumonia, and then we'll review some evidence-based tracheostomy care. And like Fernando said, I'll be joined by Katie Bull in finishing the last part of this presentation, and then we'll take questions afterwards. Now, for those of you who've attended our series of webinars, this is webinar number 3 in a series of webinars. We started with a focus on ventilator-associated pneumonia, and then we evolved into the use of airway devices in our ventilated patients and how they connect with the problem of ventilator-associated pneumonia. And today we're going to focus more on the tracheostomy tube side of things. This slide here pretty much shows the anatomy of a tracheostomy tube. I know that most of the audience on this webinar today is very familiar with tracheostomy tubes. I'm guessing uh, you all use it, whether in the ICU or other inpatient care environments. You're familiar with the basic parts of a tracheostomy tube. But just to sort of go over what we'll be talking about today, when we look at any tracheostomy tube, we want to look at we want to look at whether it is a cuffed or uncuffed tracheostomy tube. So the cuff of the tracheostomy tube, the tube itself, and the shape of the tracheostomy tube. We'll be talking a little bit about different shapes and structures of the tube material. We'll be talking about whether it has a bevel or a straight tip at the end. We'll be talking about the flange itself. Now, this one is a transparent flange, which is typically not always the case. But again, it's an important part with the connector and where the tube ties come in and tie across the neck of your patient. We'll be talking about this is the introducer and the inner cannula right here. And then this is the pilot balloon that connects with the cuff itself and the subglottic suction port. So again, some of these are routinely available in your day-to-day practice, and some of these features may be new, but we'll be opening up to the newer features as we progress in this webinar. So again, like I said, a very basic overview of tracheostomy tube types, and we can start by looking at this particular tracheostomy tube, which is a cuffed tube with an inner cannula. So here is the cuffed tracheostomy tube and the inner cannula. It can be used in a disposable fashion and or a reusable fashion. And without going into great depths of, you know, precisely where and how, I will generally say that any patient that is more or less exclusively dependent on mechanical ventilation will need a tracheostomy tube of this kind. So I look at every patient in the ICU and I look at them as their journey on mechanical ventilation. And usually that journey begins with the presence of a airway. That initial airway is usually an endotracheal tube, although that's not always the case. Your tracheostomy tube can be a primary airway, but generally the primary airway is an endotracheal tube. And somewhere along the course, the endotracheal tube then changes over to a tracheostomy tube. And this kind of tracheostomy tube, standard cuff tracheostomy tube with an inner cannula, will usually be the first tracheostomy tube. Now, I say usually again and again because it's difficult to generalize, but usually first tracheostomy tube that your patient receives while on mechanical ventilation. The cuff will stay up initially while the patient, is fully connected to a ventilator, and you do not want any air leak around the tube. Patients not focused on that time on phonating or other aspects that come in as you start weaning from mechanical ventilation. Now, this tracheostomy tube, on the other hand, is an uncuffed tracheostomy tube with an inner cannula, and again, can be used as disposable or reusable. But as we progress in the journey on mechanical ventilation, the uncuffed variants of the tracheostomy tube become more important. Now, for example, in this case, a patient who is usually on a trach collar, for example, is awake, alert, and is only using the tracheostomy as a conduit for air for ventilation and oxygenation, and really is speaking around the tracheostomy tube, or has a or is performing other functions in addition to just using the tracheostomy tube as a ventilatory conduit, will use this type of a tracheostomy tube in general. Again, not going into specific examples, but just broad strokes here. Now, the fenestrated tube you can see on your screen right now, it comes with or without a cuff. And for example, if you use it with a cuff, then it is a excellent mechanism to allow airflow through the fenestration right here and allow airflow through the vocal cords so the patient can actually phonate, and when you provide a mechanism to close the top of the tracheostomy tube on the other end. So it's a great tracheostomy tube again as the patient progresses along a weaning pathway, and these tracheostomy tubes would more or less be used in those chronically tracheostomized patients who you want to start phonating and start using their vocal cord apparatus, and also start using, for example, their swallowing mechanisms. So again, more along the mechanical ventilation journey towards liberation from mechanical ventilation. There are some problems associated with this. Again, I'm not going into the depths of those right now, but some folks have, for example, reported that around where the fenestration meets the mucosa of the trachea, there is a tendency to the formation of granulation tissue with the irritation from the fenestrated part of the tube sitting against the either sitting against the tracheal wall or just by the tracheal wall and with airflow through it. But again, in general, when used appropriately, this is a very nice transition to full liberation from a tracheostomy. So how do we choose the appropriate tracheostomy tube? If you look at the left side of your screen over here, I've provided about 9 points here, which should be the sort of the checklist in someone's head when you're trying to use an appropriate tracheostomy tube. So you look at material, you look at material. If you can look at on the other side of your screen right now, here is one with which is a wire reinforced flexible material, also a tracheostomy tube that has a adjustable flange right here, and the material itself is such that being reinforced, it will be better in patients where you need the tube to hyperextend or hyperflex as it comes out of the stoma at the neck. There is also another flexible tracheostomy tube, but the curvature seems to be slightly, it has a preformed curvature, whereas there's not, this is not the case over here. And so the use of every tracheostomy tube is essential when you consider what sort of anatomy your patient has, what is the neck thickness, is your tracheostomy high or low, and what sort of what is the distance that the tube itself has to travel between the incision on the neck and the incision on the trachea itself. Now, the other things to consider are obviously the connector and the cannula. Do you need to have a transparent connector and flange right here? I think it's essential because this will allow you to visualize around where you created the stoma, allow you to visualize whether there's issues related to stomatitis and other inflammatory changes in this area where the tube goes in. The cannula material is also important as we look at tracheostomy tubes that are more disposable versus more permanent. Cannulas itself can be fenestrated and non-fenestrated cannulas to allow for phonation and other abilities, as I just talked about. The size of the tracheostomy tube is important. Again, all sizes, all the way from pediatrics to adults, and even in adults, uh, sitting a tracheostomy tube appropriately uh, compared to the lumen of the trachea and where you place the tracheostomy is extremely important. You can see in this slide right here, the typical outer diameter is 12.2 millimeters, and it says here inner cannula is 7.5, and then on the other side in the diameter of the tube itself is 8.5. So this is more or less the standard adult, but again, there will be variations to this depending on an individual patient anatomy. The other thing to consider is the bevel of the tube. So either the tip can be beveled or it can be non-beveled. Beveled tips allow for easier insertion, and I'll talk about some of these examples as we go on. The cuff shape and material, again, this is a tapered cuff, thin cuff material, less redundancy, less fold formation, less chances of aspiration of subglottic content and contamination from above the cuff. So it's important to consider the cuff shape and material. I'll talk a little bit about the ability for subglottic suctioning, and then the use of long versus short-term tubes. And we've already touched a little bit about fenestrations and speaking valves, fenestrations right here, and speaking valve that can be added on to the tracheostomy tube itself. So this is more of a 30,000-foot view of all the factors that you should be considering, along with patient-specific factors and the primary reason why the patient has a tracheostomy tube when you consider your choice of tracheostomy tube in clinical practice. I wanted to touch a little bit upon surgical versus percutaneous tracheostomy. So on the right side of your screen right here is a typical low cuff tracheostomy tube that will generally be used for a standard surgical tracheostomy. However, a lot of emphasis in the last 5 to 10 years has been on the evolution of percutaneous um, uh, tracheostomy in the ICU, which, when done on an appropriate patient, does have better outcomes in terms of how that area heals and long-term issues with subglottic stenosis. So this here is a typical percutaneous tracheostomy set with a single dilator, a guide wire, the initial needle to puncture, and then the tracheostomy tube assembly itself. Usually, tracheostomy tubes for percutaneous tracheostomies should have a beveled tip and a tapered cuff. It's always easier to insert these versus a non-tapered cuff, non-beveled tracheostomy tube when you're doing a percutaneous tracheostomy. Now, talking a little bit about different parts of the tube, here's the importance of the flange itself. Now, a transparent flange with ties here is really nice because it allows for a improved stoma access and care. And remember, when we talk about infections, we focus a lot on subglottic secretions and secretions draining into the lungs from the subglottic area. It's also important to remember that a lot of the aspirated secretions are going to ultimately make their way to the stoma. That is the only way they're going to egress from the airway. So the ability to have visualization of the area around the stoma is critical, since this is the area that tends to get all uh, red and inflamed all the time, and this is a prime source of peristomal infection. So the ability to visualize this area and keep it clean is mission critical. And here is the transparent flange that is very important for something like this. The windows in this kind of flange also promote airflow, and definitely this in general calls for a more comfortable sort of existence for the patient with the tracheostomy tube itself. Now, these are just some other variants of the flange. The flange itself can move up or down. These are the neonatal tubes. The size of the tube is pretty obvious, not an adult tube. But the ability to move the flange up and down is also critical because, as you all know, no two patients are the same. So no two patients will have the same amount of adipose tissue and muscle layers between the skin to the actual trachea. So the ability to move the flange up and down and will be essential if you want to have a more flexible tracheostomy tube hooked up to the ventilator that doesn't drag so much on the patient and doesn't tend to move around all the time. The cuff itself, so standard cuff, sort of a low cuff right here on the right side of the screen, and the tapered cuff here on the left side of the screen. The tapered cuff itself is closer to the shaft. It makes for an easier insertion, and it has fewer cuff folds, and therefore there's less pressure on the lateral walls when you inflate the cuff. So a major consideration in tracheostomy tubes, almost a bigger consideration compared to endotracheal tubes, is the maintenance of adequate pressure and volume in the cuff. And we've talked about this in previous seminars, but the ability to have a good seal and less pressure on the lateral walls of the trachea is again critical to avoid all sorts of long-term complications of tracheal mucosal ischemia and the development of tracheoesophageal fistulas, for example. This is again a radiological view of how a standard or a tapered cuff would look like. This is a standard cuff, fits in here, but it's also exerting, it seems to be exerting significant pressure on the side walls of the trachea, where a tapered cuff is definitely a better fit into the trachea itself. And again, going on further, I talked a little bit about the adjustment of the flange, which can add an additional significant amount to the length of the stoma and what is outside of the stoma. On the other hand, these two tubes are different. This has a more right angled profile. This is slightly less than right angles. This has the tapered cuff right here. I talked about the benefits of the tapered cuff. However, this one on the left side appears to be reinforced. So again, every tracheostomy tube should be patient specific. And as I'll show you right here, the ability to adjust the flange, the ability to be more reinforced, and the ability to hyperflex the actual profile of the tracheostomy tube is essential when you're sort of dealing with a more obese patient population. So if you look at the distance between the skin surface to the anterior tracheal wall, in this patient with a BMI more than 30 and compare it to this patient with a BMI less than 30. If there is a bigger distance that the tracheostomy tube itself has to travel, then the adjustable flange becomes a very, very important feature to keep the connector and the outside of the tracheostomy tube flush with the skin, and also to allow enough of the tracheostomy tube to be inside the airway and appropriately seated. On the other hand, this patient here who is thinner, it doesn't really matter that much, but you will see that the angle of the stoma in relation to the trachea, less acute angles usually have a greater stomal length, and more acute angles have a lesser stomal length. So it's important to visualize your patient and almost visualize your patient in cross section when you choose your tracheostomy tubes. So again, to summarize what's on this slide, the choice of the tracheostomy tube, whether you want an adjustable flange, a reinforced, a flexible, or other types, would look into where you're doing your tracheostomy, whether it's a high or low tracheostomy, would look at the angle of the stoma in relation to the trachea, and would look at a overall BMI. And I gave you an example of how greater stomal depth can be expected in the obese, and that would demand a different type of a tracheostomy tube. Now, coming back to the problem of ventilator-associated pneumonia, ventilator-associated pneumonia is a global problem, and again, the figures in this slide show it's a widespread global problem. Uh, and again, the aspiration of oral or gastric secretions is directly related to the pathophysiology of VAP, and the incidence of VAP itself can be dramatically reduced and ventilator days shortened by removing secretions from the subglottic space. Now, in general, we've talked a lot about VAP in our previous seminars. I will tell you that tracheostomy tubes in the ICU are generally better for VAP. They reduce work of breathing. Patients are usually breathing spontaneously, at least to some extent, so they permit transfer to step-down units. They make oral care much easier for bedside nurses, and better oral care means less contaminated secretions going down into the lungs. It improves overall patient comfort, allows mobility, and decreases sedation needs. So all factors that actually promote less ventilator-associated pneumonia. So tracheostomy tubes in general, less ventilator-associated pneumonia compared to endotracheal tubes. Now, when it comes to subglottic secretions, um, there is enough literature in the endotracheal tube world that shows that effective drainage of subglottic secretions will decrease the incidence of VAP. I will not go through the individual studies in this table, but the percentage difference and the percentage VAP controls is anywhere from 5% in this study, nearly 20% right here, 40% here, another 23% here. And there's a whole lot of studies in the endotracheal tube world that show that subglottic secretion drainage is an effective mechanism to control VAP. However, the same principle should apply for a tracheostomy tube. Do we really do enough with our tracheostomy tubes when it comes to subglottic secretion drainage? The answer, quite honestly, is no. And the reason there is that we don't have a lot of subglottic secretion drainage ability compatible tracheostomy tubes. And this is why it matters. Ultimately, whatever's in the oral cavity is going to come down here and sit right on top of the cuff of the tracheostomy tube. And like an endotracheal tube, this is where it's liable to leak around the cuff and be a critical factor in the setting up of VAP. So what is an ideal mechanism would be to have a low volume, low pressure cuff with the tapered cuff, reduced lateral wall pressure, better seal, but also have a SSD system right here that which has a lumen that is close to the cuff, however not close to the tracheal mucosa, doesn't damage the tracheal mucosa, but still is able to suction out all of this stuff from around the tracheostomy tube cuff. As you can visualize, if you were going to try and do this through the oral cavity, it would be nearly impossible and would probably cause a lot of trauma and or other problems. So there is some literature. For example, here is one study that compared 9 standard tracheostomy tubes with 9 tracheostomy tubes with the ability for subglottic secretion drainage, and standard trachs had about 5 times a higher incidence of VAP compared to the tubes with the subglottic secretion drainage. Standard trachs also had an average of a week more on the ventilator than those with the subglottic secretion drainage. And therefore, the very obvious clinical benefits and healthcare resource expenditure benefits. So a lot of societies have now bundled SSD to be included in the VAP prevention program. And these are not only critical care societies, there are other societies that look at patient safety and so on. So pretty much we know that subglottic secretion drainage is mission critical for our patients. Here is one tracheostomy tube that does subglottic secretion drainage. It's called the Blueline Ultra Suction Aid. It has a suction lumen to aid in removal of secretions from above the cuff right here. So here is your suction lumen. It's made of thermosensitive material. It provides sufficient rigidity at the time of insertion, but then it sort of matches the body temperature, and therefore it takes the shape of the individual trachea and the airway. It is appropriately radio opaque. It has a soft seal cuff, which is a low pressure, high volume with a higher and larger cuff resting diameter. It has markings on the pilot balloon to provide other relevant information. It has a clear flange. Again, I talked about the importance of a clear flange in being able to see what sort of health the stoma is in, and whether it is free of infection and inflammation. And then it has an obturator that features a special clip to minimize tube movement during insertion. So here's one example of a tracheostomy tube with an SSD built into it. Here's one more example of a tracheostomy tube with an SSD built into it. This is the Siliflex with EVAC. It also has a transparent flange right here, and it has a taper guard cuff, which is a tapered cuff that sits snugly and allows a better seal with the tracheal mucosa. It has a bevel tip that allows insertion for percutaneous tracheostomies, a removable inner cannula, an integrated cuff inflation valve right here, and then importantly, the integrated suction lumen. It's important to know that every suction lumen that's built into SSDs does increase the thickness of the actual tracheostomy tube just a little bit. However, um, if you look at the overall benefits of what a SSD can achieve in a tracheostomy tube, the importance, I cannot understate it or state it more uh, based on what we know so far of ventilator associated pneumonia. So here's just a brief look at what we believe will probably be the future of how we manage tracheostomies, that subglottic secretion drainage has to be a part of routine tracheostomy care. So all in all, tracheostomy use in the ICU compared to endotracheal tubes, I already spoke to all the advantages of a tracheostomy tube. Less workup breathing, patients are mobile, they're up and awake, they're on lower sedation, they can walk around, they can transfer to step down units. Oral care is easier, patients are more comfortable. But if you use a tracheostomy tube in the ICU and you have subglottic secretion drainage added on to your tracheostomy tube, not only are you able to mobilize patients better and decrease sedation and do all of this good stuff, which is going to reduce ventilator associated pneumonia, but also objectively, you're able to decrease the risk of infection and reduce the risk of microaspiration, which we know are probably one of the most important and usually forgotten components of the prevention of ventilator associated pneumonia. So here is really sort of a evolution into how we have to start thinking about tracheostomy tubes in the intensive care units when it comes to prevention of VAP. At this point, I'm going to hand it over to my co-presenter, Katie Bull, and Katie is going to now talk to you all about care of the tracheostomy tube and give you a sort of a hands-on bedside demonstration of how you can better care for these tubes when you work with your patients. Thank you, Katie.
Thank you, Ashish. I appreciate that, and that was a really great review. So we're going to dive into the care of the tracheostomy, and we're going to do a focus on evidence-based practice. I know there's a lot of people on the call today that take care of the tracheostomy from the standard bedside approaches. So we're going to do a high-level overview, and we're going to actually talk about some of the features that Dr. Khanna had just discussed, but we're also going to highlight some things that are evidence-based, and as we know, practices can change over time. So we'll try to highlight any of those areas. So thank you again for reviewing the tracheostomy features, and we'll dive right in to suctioning of the airway. So of course, there's three types of suctioning, as you can see here: oral, tracheal, and then subglottic, like Dr. Khanna has been talking about. Before we get into the specifics, let's keep it really general and talk about suctioning and how it maintains the patency of the airway. Any suctioning procedure should be primarily based on assessment. So typically, we can put our suctioning on a routine schedule of at least every 8 to 12 hours, but frequent patient assessment is critical with the client of the artificial airway, with the indicators of suctioning really needing to be focused on the inclusion of excess secretions at the trach site, coughing, low oxygen saturations, even agitation or confusion. But coarse rhonchi over the trachea has been shown to be the most sensitive indicator for needing tracheal suctioning. So keeping an eye out on that should be the best approach to when our patients need to be suctioned. Next, we're going to focus right here on the tracheal suctioning, and this can always be achieved either through closed or open suctioning methods. Though the equipment differs, the procedure is very similar, and the suction pressures should be set while the suction catheter is occluded. Typically, this suction, tracheal suction, will range anywhere between 80 to 120 millimeters of mercury, not to exceed 150 per the AARC. You always want to pre-oxygenate, of course, and then insert the suction catheter just deep enough to retrieve the secretions. Again, the AARC says that deep suctioning is no longer recommended. It doesn't show that it's any more effective than typical suctioning, but is associated with more adverse events. And of course, if your client has a fenestrated tracheostomy, as Dr. Khanna showed with the slats, we want to make sure that we replace the inner cannula before suctioning to prevent that suction catheter from protruding through those fenestrated slots and actually injuring the tracheal mucosa. Next is our subglottic tracheostomy device, and it has that incorporated suction line that Dr. Khanna was showing us. We want to make sure that this type of suctioning is done a little bit differently than our traditional tracheal suctioning. It does not take place in the inner cannula, so there's no need to pre-oxygenate, there's no need for aseptic technique, and unlike tracheal suctioning, there's no risk of lung decruitment. This can be done either with continuous or intermittent suction, but you need to always check the device's instructions for use. The intermittent suction can be used anywhere between 100 to 150 millimeters of mercury, or continuous, but it must be low suction, less than 20 millimeters of mercury. It's important to know that these secretions are going to be fairly scant. It's not unusual to have just 1 to 2 millimeters per hour, and to always make sure that we are never using syringe suction. The syringe suction is too great and puts too much pressure onto that tracheal mucosal wall. Next, we'll review cuff pressure and cuff pressure management. If you've been to any of our previous sessions, we really emphasize the appropriate cuff care and maintaining cuff pressures at 20 to 30 centimeters of water, or per the manufacturer recommendations. Using thermometers is the best practice. Using more traditional methods such as minimal occluding volume or MOV may not be as accurate as the thermometer, nor should we use the feel of the pilot balloon. I know there's a lot of us out there who are used to just kind of, tactiling the pilot balloon to see if, if we feel that it's the adequate pressure, but these were not indicated to show a measurement of pressure. Often, measuring the pressure is a shared function between nurses and physiologists or respiratory therapists. This can be advantageous. However, that overlap can sometimes lead to gaps. I think you're doing it, you think I'm doing it. So it's really important to make sure there's clear policies of responsibility. Good communication is key to maximize that shared collaboration between those two functions. Next, this slide just really is meant to show an illustration and emphasize under and overinflation. Obviously, underinflation leads to aspiration. Overinflation causes decreased perfusion of that mucosa and contributes to injury. Although underinflation can be noted through auditory leaks or loss of ventilation pressures, overinflation is often silent. So it's really important, again, emphasizing the importance of proper cuff checks and care routinely to make sure that that isn't going on. Then finally, we'll look at the skin and the stoma. Obviously, clean and dry is always the goal. It's easier said than done. Obviously, there's always some factors that impact the overall skin and stoma can vary. External forces, as you can kind of see here on the screen, will pull onto that trach and cause excess pressure on the skin. So the weight of the ventilation equipment, friction from manipulation. So us really, just kind of moving it around to try to see what's under there if it is not a transparent flange. And then of course, any secretions that get underneath there. Patient characteristics can also add to this. Again, the patient's specific anatomy can cause extra challenges if they have decreased perfusion due to comorbidities or even decreased nutrition. All plays a part in good skin care and really should be flagging us to make sure that we're looking at those things to see at who's even at a higher risk for skin breakdown and stoma care. The next is accidental decanulation. Unfortunately, is a risk for any patient with a trach tube. This can happen during routine care, even weight, excess weight from ventilation equipment. Again, patient characteristics can increase the chances, whether they maybe have increased activity, obesity, agitation, swelling of the neck, excessive coughing. All of these things can play a part in increasing the risk of an accidental decanulation. There's a couple of things that we can do when cleaning the skin and the stoma area. Make sure that we're keeping that trach secured, and this can either be done by keeping the trach ties intact during care or using that buddy system, of course. Ensuring neutral positioning, preventing pulling from the ventilation equipment, and maintaining trach ties with only 1 finger depth can minimize the risk as well. And then, of course, sometimes things happen, so making sure that we're always prepared, keeping that replacement trach and a trach that's even one size smaller at the bedside and with the patient at all times is important in the event that it does become accidentally dislodged. If the stoma is well established, you can reinsert that replacement trach, or if you cannot reinsert that, we can always mask ventilate until oral intubation or reinsertion can be achieved. If the stoma is new, of course, we want to mask ventilate until orally intubated because we don't want to go ahead and potentially disrupt the new site. So hopefully this gives you some extra thoughts and some new information that is a little bit, again, new to the standards and evidence-based practice, and hopefully it gives you some confidence moving forward in the event that we have some emergency needs. Next, I'll turn it back over to Dr. Khanna.
Thank you, Katie. That was a great presentation of the how-tos with a tracheostomy tube. I'm going to end our talk today requesting all of you to stay safe, stay masked up. I know that it's been a long and tiring year for everyone. But one day we're going to look back at 2020 and know that we did the right thing for ourselves by taking precautions, as my 6-year-old son is doing here, and also a fact that all of us have suffered a lot. We've lost colleagues. Some people have unfortunately lost family members. Um, but the virus is relentless. I salute all of you who are in some way, shape, or the other taking care of patients in the hospital or in medical systems around the world. If it were not for you all and all the good things that you're doing, the world would be a very different place right now. So, thank you for all that you're doing. Um, Stay safe, protect yourself, protect everyone else around you, and we're happy to take questions as we finish up this webinar today.
Thank you very much, Dr. Khanna. I want to subscribe to your words about thanking everybody for being there. I absolutely agree that this world would be different without all of you there. So thanks for that. Before we start with the Q&A session, I want to remind a couple of logistics here. One is, if you remember, this is an accredited seminar for nurses, EMS professionals, and respiratory therapists. If you want to receive a certificate, all you have to do is go to www.saxetesting.com/init. Remember to put that www before this word. You will need to register there, complete a survey, and after that, you will be able to download your certificate. In the case of EMS professionals, your certificate will be mailed to you. We want to remind that this session has been possible with the support by Medtronic. Also, the recording of this event will be available on demand in about 10 days at the website that you can see there, initiatives-patientsafety.org. The on-demand version will also be accredited for nurses, EMS professionals, and RTs. With that, I'm going to move to the series of questions we have here. We have a good amount of questions, so we are going to move right away into it. Dr. Khanna, are these track ties, tracheostomy ties or track tube holders, are there any that you wouldn't recommend?
That's a good question, Fernando. Not really. Obviously, the important things universally with all trach ties is to make sure that trach ties are tied securely, but they are never tied too tight. If you go ahead and really tie them too tightly, then you risk venous engorgement from large vessels that are draining through the neck. And obviously, you will actually cause more injury around the stoma if you're too tight with your trach ties. I personally do like the newer trach ties that you don't actually have to put a knot in the ties, where you have a Velcro that you can stick on. But again, I know every institution has their own practices and whatever they're comfortable with. The guiding principle is to have it secure, but not have it too tight.
Perfect. Katie, a question here says, do you teach families, and this is for adult management, do you teach families to change tracks at home or refer them to the ENT clinic?
That's a really good question, and I think that it would rely more so on the provider and what the facilities and the providers are comfortable with. Typically, every facility has a discharge instruction, not necessarily a kit, but almost a curriculum, so I would follow that. Typically, the first trach changes is always done by the provider, but if it's a well-established stoma and it's within the facility guidelines and the family and or the patient is comfortable with it, those would be the key things. So it can be done, but making sure that it's right for your facility and right for the patient and right for the family is always the key answer there.
Great, thank you. Dr. Khanna, do you think that the use of chlorhexidine for oral care can help decrease the rate of VAP for patients with a trach?
Oh yes, absolutely. The principles of ventilator-associated pneumonia are by and large still the same, whether you look at an endotracheal tube or you look at a tracheostomy tube. So oral secretions or oral care and keeping the oral cavity clean would definitely decrease the bacterial load in the subglottic secretions, and decreased bacterial load in subglottic secretions means even if there is some amount of microaspiration, it will not do as much damage, compared to if you had not cleaned out the oral cavity. So, decreasing oral contamination is an absolute no-brainer. It should be done whether your patient has a tracheostomy or an endotracheal tube.
Fantastic. Dr. Bull, a follow-up question to the one you answered before. For patients at home, do you also teach them how to make the changes? And if you do, how often? Anita is saying that in pediatrics, that she also works, we teach weekly as they have single lumen cannulas.
That's correct. Absolutely. So the most important thing is to always go by the manufacturer's guidelines, because different types of tracheostomy tubes, whether it's a PVC or maybe it's silicone, will have different directions and durability, as well as the recommendation for the duration of use. So typically a PVC tracheostomy tube may say that you cannot use it beyond 29 days. So that's the maximum. However, again, it really goes by your patients. And again, what tube, is it single or double cannula, and what type of care is required. The ultimate piece here is that we have to make sure that the tube can maintain its patency. So if you have somebody who is really produces a lot of secretions, or especially a lot of really thick secretions, somebody like that may need to be in a tube that has either a disposable inner cannula, or if you have a single cannula device, they would probably require it to be changed much more frequently. But what you're saying seems to be right on point of what we see in typical standard care, is those single pediatric devices are typically changed about once a week, but it really depends on what the patient needs, but always making sure to follow the manufacturer guidelines based on that material and what that tube has been validated to be.
Okay, for the following questions, I'm going to ask both of you to be as brief as possible. I want to push as many questions as we can, and we still have a lot with only 5 minutes left. Question from Lisa is, why choose a non-disposable inner cannula or a disposable inner cannula, Dr. Khanna?
Just depends on why your patient has had a tracheostomy, and specific situations will need a disposable or a non-disposable. I would again say that in today's day and age we are more and more relying on disposable cannulas. However, there are still situations where non-disposable reusable cannula could be utilized if needed.
Perfect. Dr. Bull, can you give us some elaboration on while the patient is speaking and eating while on the vent?
I'm not sure I understand the question. Can they eat and speak while on a vent?
Absolutely, yes.
Okay, well, I will defer that back to Dr. Khanna for your provider recommendations there.
Sure, happy to answer that. So yes, patients can definitely eat and speak while on the vent. So some of the tracheostomy tubes I showed early on in my slides, specifically the fenestrated tube and the uncuffed tube, could be used while a patient is speaking on the vent. So the philosophy there is, as the patient gets stronger, as you're able to keep the patient off sedation for longer periods of time during the day, for example, then a patient should be awake and alert, should have a good cough reflex that you should either do a clinical test on, or a bedside swallow, or have your speech therapist come and evaluate, or send the patient for a radiological examination of the swallow and cough reflex. Once you determine the swallow and cough is intact and the patient's able to clear their own secretions and cough them out, then eating can start. At the same time, the patient can either have a cuffless tube or have a cuff tube where the cuff can come down for a little bit. Every time the cuff comes down, the patient would be able to phonate around the tube, or have a fenestrated tube with the cuff up. The good news there is that patient could still speak, the cuff would stay up, which would mean that even if there is some microaspiration of food or secretions, that shouldn't cause too much damage. Now realize that that eating and speaking with a tracheostomy tube on the ventilator is a very advanced function. It needs, I would recommend it being done only after you're 100% sure that your patient has really reached a point where they are on their way out of the ICU.
Fantastic. Dr. Bull, is there any indication for what if filled cuffs as tracheostomy cannulas?
How they feel? Was that the question?
Well, the question is, do you ever use what if filled cuffs? What are the indication of this kind of tracheostomy cannula?
Well, cups really need to be used. Dr. Khanna went through this at the beginning with, cups need to be used whenever we need to maintain the ventilator settings, or if there is an increased risk of aspiration, they're unable to maintain those secretions. Very similar to what he just said. But as a part of that weaning process, they can then move into the cuffless as a part moving towards weaning and speaking and regaining that the ability to breathe more naturally. Did that answer the question?
I think so.
Okay.
And I'm going to finish with one last question because I think it's very timely, Dr. Khanna. The COVID-19 pandemic has changed practice in some institutions. I have seen the tracheostomy procedure being delayed beyond 2 weeks on oral tracheal intubation due to concerns of aerosolization and transfer of infection to others. Would you agree that this is increasing morbidity and mortality? And then a subsequent question to this one would be that how often would you, or what are your thoughts about tracking patients with COVID?
Yeah, it's a very timely question indeed. Initially when COVID started, there was a huge reluctance to put a tracheostomy in these patients because, the aerosolization contamination was a big issue. I've seen a time when patients would not get a tracheostomy for 3-4 weeks at a stretch. I think things have evolved, and we're at a stage now where we are putting a tracheostomy in almost using the same criteria as we would use for a non-COVID patient. And while there is no clear recommendations are more based on institution may choose to follow a certain guideline based on what its providers feel comfortable with. So, for example, at our institution, we are putting tracheostomies in at 2 weeks out from intubation. I think that's reasonable, and in the due course of time, that's going to come down even further. There is a lot of data that suggests that infectivity of COVID-19 after 10 days of initial symptoms or initial exposure to infection really starts going down. So our providers are using standard PPE and are putting tracheostomies in starting 2 weeks out. It does decrease morbidity and mortality. One of the biggest problems with COVID-19 that we have seen is that prolonged endotracheal intubation leads to endotracheal tube blockage, and I have personally seen a lot of physical um, consequences of endotracheal tube blockage. So allowing these patients to get early tracheostomy allows them to come off sedation, wean off sedation, get off the mechanical ventilator faster, mobilize faster, and prevent superimposed pneumonia. So nothing like early tracheostomy if your institution can allow that.
Fantastic. With this, we are going to stop the webinar here. There are many questions that haven't been answered, so if you want, send them to us and we will pass them to the speakers. Remember, I'm going to pass it to Tracy so she can conclude it.
Thank you. Thank you, Fernando, and thank you to our speakers today. We'd like to also thank everyone for attending today's session. Immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open, and we appreciate your feedback. To attain your CE credits, please visit www.saxtesting.com/INIT, register at the site, and complete the evaluations. Thank you. This concludes today's session. We hope you have a wonderful day.